LPA issues are fundamentally a little bit different than cholesterol issues. My name is Dr. Michael Koren, and I'm delighted to moderate another session of MedEvidence. And we're very fortunate today to have a special guest, Dr. Dennis Leahy from San Diego, who's going to talk about lipoprotein(a) from both the perspective of a clinical cardiologist, interventional cardiologist, and also a patient that has this problem.
I'm a classic Lp(a) person in that I had a very strong family history of vascular disease. Probably came mostly from my mother's side of the family.
This family history concept is really, really important. So going back to my cardiology days, one of the things that struck me when I first learned about LPA is the really, really strong family history of people with this problem. So you'll get folks, for example, that have a father and mother who had some complications in their 20s, 30s, or 40s. And this is following each generation down the road. So, and to that point, I did my training at New York Hospital, and one of the famous LPA patients at New York Hospital was Arthur Ashe, who had this type of family history of having both mother and father have heart disease at a young age. And Arthur Ashe, as a fit professional athlete, had his first cardiac issue at age 29. So it was a very profound introduction to me of this particular problem.
So in 2002, you'll probably recall, Lp(a) was known. I mean, it's been known as a lipid particle for some time, but there's a real struggle to figure out whether it's strictly a biomarker or a causative agent for vascular disease. And in 2002, things were every bit as murky as they were before that. But I was kind of a typical Lp(a) patient and remain so, in that if you look at me and you looked at 10 other people in the room, you'd say, who's the last guy here to get vascular disease? And it would probably be me. I've always been very fit. Right. I've exercised all my life and had virtually no other risk factors.
Just for the audience, LPA is measured in different ways. In fact, there's kind of a debate of the best way to measure it. But the two major ways of measuring it are either by mass, and the typical measurement there is milligrams per deciliter, or by concentration, and then the typical measurement would be nanomoles per liter. And they are related to each other, but because lipoprotein(a) is a heterogeneous molecule, more and more of us think that the concentration is a better way to describe it, because each particle can actually have a different mass, and it's hard to know your risk based on, quote, the size of your particles. So just looking at the overall concentration of particles is probably the way most of us are going in the lipid field.
So anyway, I was doing my usual thing, and then a very important moment in my life was New Year's morning on 2007. So this is about 4 years after I had my negative calcium scan. I was surfing. It was a cold, windy morning for San Diego, and kind of an arduous paddle out. And I had my first episode of chest pain when I was paddling out. And I knew exactly what it was, having been in this position with thousands of patients over the years. Kind of backed off and got into the beach. The pain was gone, but I was quite certain I was now living out my legacy here as a Leahy. And indeed, so then I did get a cardiac workup. And had some stents placed shortly thereafter. 3 months after my stent procedure, I was surfing, same beach, same situation, had chest pain again.
Was that is that standard cardiac rehab in San Diego, is surfing?
It is for me. And so sure enough, I had restenosis in one of the stents. The other one didn't look too bad at that time. And we decided to stent within the stent with a different coating. These were drug-eluting stents. Never had any issues with blood pressure, always at ideal weight, no diabetes, never a smoker. It was pretty much Lp(a), and then perhaps not perfectly ideal LDL, as I said, with my 2002 readings. Part of the good fortune of my story, I guess the bad fortune is I have this problem, but the good fortune is I've had access to world-class healthcare, and that's really gotten me through all this. Ionis Pharmaceuticals, where they have developed this ASO, or antisense oligonucleotide treatment for Lp(a), which is a gene-slowing approach to try to suppress Lp(a) production. Right. They'd had one successful phase 2 trial, and they were starting another one. And it sounded like a great option because unlike other trials where it's frequently a 50-50 chance of getting active treatment, this was a dosing trial, so I had a 5 out of 6 chance of actually being on an active drug.
Mhm.
So I was in that study for 1 year with, as you know, successful and impressive suppression of Lp(a) production. With I think I was on a once every 2 week injection, subcutaneous injection, very simple procedure, which has been shown to be quite safe with minimal side effects.
And this is the molecule that we call pelacarsen now. Is that correct?
Right.
Mhm.
Right.
And antisense oligonucleotide that actually prevents the production of the protein that is essential for the assembly of lipoprotein A right outside the nucleus of the hepatocytes. So that's a fascinating technology and really, really exciting. And so exciting that, as I understand it, Novartis bought the product.
Right. Novartis, of course, is in hopefully towards the end of a trial, a major trial that will be a really, really a landmark kind of pivotal trial, whether these things are going to result in lower incidence of cardiovascular events by suppressing Lp(a) production. The thing that I have actually written a couple pieces on that have been kind of op-eds that have gotten on a couple online sites is I feel very passionate that everyone in the world should be tested for their Lp(a) level. I think it's an extremely important part of where we're going with Lp(a). I don't want to get too far in the weeds if this is not something you want to pursue, but you only need to be tested once to be
Mhm.
essentially to stratify your risk because the level doesn't change much. From age 5 onwards, your Lp(a) level is going to be your Lp(a) level. Well, Lp(a) has kind of suffered a weird history in that it really hasn't ever gotten the attention it deserves, even though I think particularly the past decade, the elegant research that you and other people have been involved in have really clarified its role and given a direction to how we should treat it. But that is not translated well in the clinical world. You talk to the average doctor on the street and ask them about Lp(a), and they're still kind of mystified. And part of the reason for that is it was always thought to be non-modifiable, but now we know it is modifiable and probably safely so.
Getting a little technical, the trials that we're doing now here that we are enrolling for involves something called small interfering RNA, which is another, quote, genetically based way of preventing the assembly of lipoprotein a. And it involves something called the RNA-induced silencing complex, which is part of all the cells that's actually trained to look for pieces of genetic material that can cause problems. It's a sort of an intrinsic mechanism of cells to prevent viruses from doing damage. So they're looking for sort of bad pieces of genetic material. And we can train these parts of the cells to identify the strands that are important for making lipoprotein a. And with this technology, it seems incredibly safe so far. We're able to reduce levels of LPA by up to 95%, as mentioned. So the next step is to see whether that huge reduction in LPA will translate into fewer heart attacks and strokes for people at extremely high risk.